Good morning. I'm Mary. I'm going to be moderating this session. This is such a big room. If everyone could kind of move into the middle, and would be really helpful for our speaker. Ready? So we're going to go ahead and get the session started. It's my pleasure to welcome you to Management of Hodgkin Lymphoma Status Post-Autologous Hematopoietic Stem Cell Transplant. That's kind of a mouthful. A few housekeeping items first. You can find complete speaker bios located on the HOPA website under Conference Web Central. We ask that you hold all of your questions until the end. There will be microphones located throughout the audience. And to participate in the polling questions for this session, open a web page browser and enter ra.ombea.com. The session ID for this session is HOPA1. This can also be accessed through the polling feature on the mobile app. Polling will not activate until the speaker has reached a polling slide. And it is my great pleasure to introduce your faculty. Sandy Horowitz is Clinical Oncology Pharmacist at MD Anderson Cancer Center. Sandy?
Thank you, Mary. Good morning. Thank you for inviting me to be here today. And we'll be discussing the management of Hodgkin lymphoma, status post-autologous hematopoietic stem cell transplant. And as Mary said, that's kind of a mouthful. So from here on in, I'll be referring to that as auto stem cell transplant. I have no potential or actual conflicts of interest. And our objectives today are to identify risk factors associated with relapse after autologous stem cell transplant in patients with Hodgkin lymphoma. And in those patients at high risk for relapse, we're going to review the role of consolidation therapy with brentuximab vedotin. We're also going to describe the role of PD-1 inhibitors in the treatment of patients with relapsed Hodgkin lymphoma, status post-auto stem cell transplant. Couple of fast facts. Hodgkin lymphoma affected approximately 8,500 people last year, and 1,120 deaths were recorded. It has a bimodal age distribution, young adults and older adults, but it primarily affects young adults, usually patients between 20 and 30 years of age. The peak in older adults is smaller. So when we talk about this disease, we're talking about young patients. Hodgkin lymphoma is broadly divided into two main types: classical Hodgkin lymphoma, which is classified by the Reed-Sternberg cell, which comprises 95% of Hodgkin lymphomas, and nodular lymphocyte-predominant Hodgkin lymphoma, which comprises 5%. Today we'll be discussing classical Hodgkin lymphoma. Classical Hodgkin lymphoma is further divided into four types: nodular sclerosis, which is the most common type, which comprises around 85% of classical Hodgkin lymphoma; mixed cellularity, which tends to affect a little older population, which comprises around 10 to 15%, and lymphocyte depleted and lymphocyte rich, which are relatively rare. In newly diagnosed patients with Hodgkin lymphoma, ABVD plus or minus radiation, depending on stage, is the standard of care, and it confers a 5-year overall survival of 86.2%. Unfortunately, up to 10% of patients with advanced stage disease will not achieve a CR. And of those patients who do respond to initial therapy, 20 to 30% will relapse. Salvage chemotherapy, followed by high-dose chemotherapy and auto stem cell transplant, is the standard of care for these patients. It's based on several trials that have shown an increase in event-free survival and freedom from treatment failure versus salvage chemo alone. Unfortunately, no difference in overall survival has been seen. Now, even after these patients receive an auto stem cell transplant, approximately 50% of those patients will relapse. Most relapses occur within a year, and the median overall survival is only 2.4 years, which is dismal in this young population. So it's clear that new treatment options are needed. So how do we treat these patients? Traditional chemotherapy has been tried, novel agents have been tried, allogeneic stem cell transplants or allotransplants have been tried. Unfortunately, myeloablative transplants were associated with a high treatment-related mortality, up to 40%, due to complications such as GVHD and infections. Reduced intensity conditioning transplants had a lower treatment-related mortality, but had increase in relapse. Recently, there's been some data showing that haploidentical transplants may have more favorable outcomes, but more studies are needed. And again, allotransplants are only for select patients. So in these patients, prevention is key. We want to identify those patients for risk of relapse and try to prevent it. So just to take a broad overview of the treatments that have been studied, you can see in terms of traditional agents, such as vinblastine, bendamustine, and gemcitabine, there's been a small number of patients. The overall response rate has ranged from around 20 to 60%, with a reasonable number of CRs, especially in the bendamustine group, where they had 33% CRs. Unfortunately, the event-free survival and the progression-free survival were relatively short at 5 to 8 months. When they looked at combination regimens, they found a higher overall response rate of 70% with a CR of almost 20%, but the event-free survival was still short. And in these patients, you can see that there was a lot of toxicity. The major toxicities seen were grade 3 and 4 thrombocytopenia, neutropenia, and anemia, and infections were also seen. In the gemcitabine, navalbine, and pegylated liposomal doxorubicin group, or GVD, the toxicities were more severe. Again, these patients have been through an autostem cell transplant. When they looked at novel agents such as everolimus, panobinostat, and lenalidomide for these patients, panobinostat had the largest patient study population. But you can see that the overall response rates were, again, around 20 to 45%. But the CRs were smaller than those that were seen with traditional chemotherapy. Again, the time to progression and progression-free survival was short. The toxicities seen were similar, with grade 3 and 4 cytopenias, and everolimus had the added toxicity of pulmonary toxicity, which is something you want to keep in mind if you are going to treat one of your patients with everolimus. So just to put this into perspective, you can see a graphical representation of the treatment options that have been studied in relapsed Hodgkin lymphoma after autostem cell transplant. The efficacy ranges anywhere from around 20% to around 70% with combination traditional chemotherapy regimens. The complete response rates are relatively low, and we definitely need new treatment options in these patients. Enter brentuximab vedotin. So what is brentuximab vedotin? It's an antibody-drug conjugate. It's an monoclonal antibody against CD30. Now, Reed-Sternberg cells, which are associated with Hodgkin lymphoma, express CD30. So it seemed to make sense that that would be a target for this therapy. I'm just going to go back, sorry. So what happens is that the antibody to CD30 attaches to the Reed-Sternberg cell. It's internalized. And then the MMAE, which the antibody is connected to, is released. And MMAE, or monomethyl auristatin E, is a potent antitubulin agent. And that disrupts the tubulin network, leading to G2M cell cycle arrest and ultimately apoptosis of the Reed-Sternberg cell. So the pivotal trial was done for brentuximab vedotin, was done in patients with relapsed refractory disease after Hodgkin's, after autotransplant. Again, they were CD30 positive. They had a good ECOG performance status and adequate organ function. Patients received brentuximab vedotin 1.8 mg per kg every 3 weeks for up to 16 doses. Patients were monitored by CT scans and PET scans. When we look at the baseline characteristics, again, the median age as expected was young at 31. The median number of prior chemo regimens was 3.5, with the most heavily treated treatment receiving 13 prior regimens. And 71% of these patients had primary refractory disease. Even with these baseline characteristics, you can see that in terms of their response to most recent chemotherapy, the patients had stable disease or progressive disease or unknown in more than 50% of the time. And the median time from auto stem cell transplant to the first post-transplant relapse was only 6.7 months. Again, that's expected, as most of the relapses occur within the first year. So even within this poor population, you can see that the overall response rate was 75%, with 34% of those being CRs. That's pretty amazing. The duration of the objective response was 6.7 months. And for patients who achieved a CR, the duration of response was 20.5 months. And the overall survival was 22.4 months. In terms of adverse events seen, the two main adverse events seen were peripheral sensory neuropathy, which was seen in 42% of the patients, with 8% being grade 3, and neutropenia, which is seen in approximately 20% of patients, with 14% being grade 3 and 6% being grade 4. Now, a 5-year follow-up showed that these responses were durable. The median overall survival was 40.5 months, with median progression-free survival being 9.3 months. What's interesting is 38% of the patients who achieved a CR, which was 13 out of the 34 patients, have remained in remission for more than 5 years. And 9 out of those 13 patients have remained in remission without receiving a consolidative allotransplant. So that's how brentuximab vedotin got its first FDA indication for Hodgkin lymphoma, which was a treatment of classical Hodgkin's lymphoma after failure of auto stem cell transplant or after failure of 2 or more prior lines of multi-agent chemotherapy in patients who were not auto stem cell transplant candidates. The dose, again, is 1.8 mg per kg. We max out the weight at 100 kg for a dose up to 180 milligrams IV over 30 minutes every 3 weeks. For patients with creatinine clearance of less than 30, it's recommended to avoid use. Child-Pugh A, 1.2 mg per kg up to 120 mg IV over 30 minutes every 3 weeks. And patients with moderate to severe hepatic dysfunction, avoid use. In terms of dose modifications, the 2 main ones are for peripheral neuropathy. If patients have grade 2 or 3, you want to hold the dose until it decreases to grade 1, and then restart at 1.2 mg per kg, and discontinue the drug if patients have grade 4 toxicity. For neutropenia, you want to hold it for grade 3 or 4. If patients have recurrent grade 4, despite growth factor support or prophylaxis, decrease it to 1.2 mg per kg or discontinue the drug. So now that they found that brentuximab vedotin had really good response rates in patients who have relapsed after auto stem cell transplant, they wanted to see if they could avoid using the drug after patients relapsed to see if they could prevent relapse after auto stem cell transplant. So they looked at risk factors for relapse after auto transplant, and they found that refractory disease or relapse less than 12 months after frontline therapy, extranodal disease at pre-auto transplant relapse, B symptoms at pre-auto stem cell relapse, and B symptoms, just as a review, are fevers, night sweats, drenching night sweats, unexplained weight loss of 10% or more in the previous 6 months, positive FDG PET scan pre-auto stem cell transplant, and 2 or more prior salvage regimens. So we're going to look at brentuximab vedotin consolidation after auto stem cell transplant. The ATHERA trial was the first phase 3 randomized double-blind placebo-controlled multicenter trial in Hodgkin lymphoma. The eligibility was refractoriness to frontline therapy or relapse less than 12 months after frontline therapy, or extranodal disease at the start of pre-auto transplant salvage chemotherapy. And the patients had to be responsive to chemotherapy. They had to have either a CR, PR, or stable disease. And they also needed adequate renal function and or other organ function. 329 patients were enrolled. The primary endpoint was progression-free survival as per independent review. So what happened is these patients received a transplant. After the auto transplant, they were then randomized 30 to 45 days later to either brentuximab vedotin, 1.8 mg per kg, day 1 every 21 days for 16 cycles, or placebo at the same schedule. What's important to note is patients who had progressive disease on the placebo arm were able to subsequently receive brentuximab vedotin on a different trial. So select baseline characteristics. Again, you're talking about a young population in their 30s, good ECOG performance status, and 40 to 50% of these patients had received 2 or more previous lines of therapy. In terms of what patients received up front, around 75% of them had received ABVD, and as a conditioning regimen for their auto stem cell transplant, around 60% had received BEAM. More baseline characteristics we saw was that over 90% were refractory or had relapsed less than 12 months after the transplant, after frontline therapy, and their best response to salvage chemotherapy was around 70% with either CR or PR. Around 40% had positive PET scans prior to starting the salvage chemotherapy, and 30 to 33% had extranodal involvement at auto stem cell relapse, pre-auto stem cell relapse. So we're going to look at the efficacy. I'm sorry for the poor quality of the slides, but as you can see from the top slide, the median progression-free survival was significantly better for patients who received brentuximab vedotin consolidation at 43 months versus 24.1 months in the placebo group. And the 2-year progression-free survival rate was 63% in the BV group, or brentuximab vedotin group, versus 51% in the placebo group. As you can see from the bottom graph, there was no difference shown in overall survival. And when they did a post hoc analysis of the risk factors, they found that the more risk factors a patient had, the more they benefited from consolidation therapy. Those changes were statistically significant. When they looked at hazard ratios for overall survival, they weren't significant, but they did show a trend, again, for conferring more benefit in patients who had more risk factors. In terms of adverse events, you can see that over 90% of patients had any adverse event, with more grade 3 and 4 events happening in the brentuximab vedotin group. Peripheral sensory neuropathy, again, was the main toxicity seen. It occurred in more than 50 patients with getting the brentuximab vedotin versus less than 20% in patients who didn't. Neutropenia, again, was seen. Peripheral motor neuropathy was also more common in the brentuximab vedotin group, as was nausea and diarrhea. Upper respiratory tract infection, fatigue, and cough were similar amongst groups. So there was a recent update at 3 years on these patients, and you can see that the responses seem to be durable. The placebo group, which is on the bottom, the dotted line on the bottom, shows that the median progression-free survival was 15.8 months, whereas in the brentuximab group, it hasn't yet been reached. So the ATHERA trial led to the second indication for Hodgkin lymphoma for brentuximab vedotin, and that's patients with classical Hodgkin lymphoma at risk of relapse or progression as post-auto stem cell transplant consolidation. So here's our first ARS case. AP is a 28-year-old female diagnosed with stage 3A classical Hodgkin lymphoma, nodular sclerosis. She was initially treated with ABVD times 6 cycles and achieved a CR. 10 months after treatment, she returns with biopsy-confirmed relapsed nodal disease and receives ICE times 3. Repeat CT PET reveals improved but persistent disease, and the decision is made to proceed with auto stem cell transplant. Based on this information, what is the most appropriate treatment for AP? A, auto stem cell transplant followed by observation. B, auto stem cell transplant followed by allo stem cell transplant if the patient achieves a CR. C, auto stem cell transplant followed by consolidation therapy with brentuximab vedotin. Or D, auto stem cell transplant followed by maintenance gemcitabine. Okay. I don't think it's working. So it is? Okay. There you go. Okay, so I think we're good? Okay. So we're going to lock out And you can see that most of you picked C, and that's totally correct. So the reason is that AP has certain risk factors for relapse status post-auto transplant, and those included an initial duration of response of less than 12 months, and she had a positive PET scan prior to starting her salvage therapy or prior to transplant. She had nodal disease, but that's not a risk factor. Extranodal disease is the risk factor. So what happens after brentuximab vedotin? Many patients will eventually become refractory, and the median progression-free survival associated with treatment following brentuximab vedotin is only 3.5 months. So new treatment options are needed, and duration of depth of response is important. So what we've been looking at is immunotherapy in Hodgkin lymphoma, in particular anti-PD-1. So classical Hodgkin lymphoma is characterized by the expression of programmed cell death ligand-1, which is PDL1, and ligand-2, PDL2, on Reed-Sternberg cells and on inflammatory cells in the tumor microenvironment. And this allows for evasion of immune surveillance. And the overexpression of PDL1 and PDL2 in classical Hodgkin's lymphoma frequently occurs in the setting of genetic amplification of the 9p24.1 locus. And just as an aside, this amplification of the 9p24.1 locus in newly diagnosed patients has been associated with shorter progression-free survival and advanced stage disease. So we'll be talking about nivolumab and pembrolizumab. So just a little bit about the biology behind the PDL1 and PDL2 expression in Hodgkin lymphoma. You can see that there's 9p24 amplification, which leads to increased gene doses of PDL1, 2, and JAK2. JAK2 increases the transcription of PD1, and there's also AP1, which is a promoter, which also increases transcription of PDL1 and 2. There's also thoughts that the EBV virus, which is associated with some forms of Hodgkin lymphoma, may also activate AP1, thereby increasing transcription of PD1. And the microenvironment also secretes cytokines that can increase the transcription of PD1. So just as an overview, why PD1 is a target in Hodgkin lymphoma. So you can see in the first panel that with the normal immune system, the tumor cell and the T cell meet, and the T cell is activated, and there's increased proliferation, cytokines, and cytotoxicity. In frame B, you see that you have the T cell, which expresses PD1, and the tumor cell, which is expressing PD ligand 1. When they meet, the T cell becomes exhausted, and you have decreased proliferation, cytokine release, and cytotoxicity. Now, to restore the immunologic function of our T cells, what we've done is we've taken PD1 inhibitors, which blocks the interaction between PD1 and the PDL1 and PDL2 ligand on the tumor cells, and then you have effective T cell function, again, with increased proliferation, cytokines, and cytotoxicity. We'll first be looking at nivolumab. Checkmate 39 was a phase 1 study looking at patients with relapsed refractory classical Hodgkin's lymphoma who had one or more prior chemotherapy regimens, had measurable disease, good performance status, no autotransplant within the last 100 days, no CNS cancer, no autoimmune disease, and no organ allograft or allo stem cell transplant. And this makes sense because of the fact that it's immune therapy. The first part of the study was a dose escalation cohort where patients received nivolumab at doses of 1 to 3 mg per kg. The maximum tolerated dose wasn't reached, so the expansion cohort of 23 patients used a dose of 3 mg per kg at weeks 1 and 4, and then every 2 weeks for up to 2 years. The primary objective was to evaluate the safety and side effect profile of nivolumab. Again, baseline characteristics, young age, good performance status, and 65% of these patients had received 4 or more previous lines of therapy. And 78% of patients had received either brentuximab vedotin and or an auto stem cell transplant. So when we look at the efficacy, when we look at the objective response rate in this heavily pretreated population, there was an 87% objective response rate, which is pretty impressive. And of those, 17% of those were complete responses. Now, when they looked at subgroups, patients who had failed both auto stem cell transplant and brentuximab vedotin, which was 15 patients, they still had an 87% objective response. Their complete response was a little lower, but still, the 87% response is impressive. Progression-free survival at 24 weeks was 86%, and it was 85% in the refractory group who had failed auto stem cell transplant and brentuximab vedotin. The median overall survival was not yet reached. So this led to Checkmate 205, which is a phase 2 study, again, enrolling patients with relapsed refractory classical Hodgkin's lymphoma. They had an auto stem cell transplant failure, good ECOG performance status, good organ function, and a DLCO of greater than 60% in patients with prior pulmonary toxicity. And that's because nivolumab has shown to have pulmonary toxicities. And they also had no chest radiation within 24 weeks and no prior allo stem cell transplant. Now, this was divided into 4 cohorts. Cohorts A through C were done in patients status post auto stem cell transplant failure, and cohort D was different. It was nivolumab and chemo in newly diagnosed advanced stage patients, and we won't be discussing that. And these patients were given, and the difference between cohorts A and C is their brentuximab vedotin exposure. So in cohort A, patients had failed auto stem cell transplant, but they had never received brentuximab vedotin. In cohort B, they had failed auto stem cell transplant and had received brentuximab vedotin subsequently. In cohort C, they had received brentuximab vedotin before and or after stem cell transplant. So the cohort that got the approval for nivolumab was cohort B. And patients were given nivolumab 3 mg per kg IV every 2 weeks until progressive disease, maximal clinical benefit, or unacceptable toxicity. And the primary endpoint was overall response rate by independent radiologic review committee. Patients had PETs at week 17, 25, plus or minus week 49, and the TSH, free T4, and T3 were studied at baseline and every 6 weeks. Baseline characteristics, same old. Median age was young. 85% of patients had advanced disease. The median previous lines of therapy was 4. 49% of patients had 5 or more previous lines of therapy. 74% had previous radiation therapy. And 6% of patients had more than 1 auto stem cell transplant. By design, all of the patients in cohort B had previous brentuximab vedotin therapy, and 8% had more than 1 line of brentuximab vedotin, but 54% of those patients didn't respond to their last treatment with brentuximab vedotin. So the overall response rate seen in this patient population was 66.3%. Again, that's really high in this heavily pretreated population. CR was a little lower at 9%, with 58% partial responses. So at the 12-month follow-up, the median duration of response was 13.1 months. Median progression-free survival was 14.8 months, with a 54.6% progression-free survival rate, and the overall survival rate at 12 months was 95%. So just as a little glimpse, we recently got an update on the cohort C efficacy. So cohort C was brentuximab vedotin before and or after stem cell transplant. You can see that the overall response rate was actually a little higher than it was in cohort B at 73%, with a little higher incidence of complete responses, and partial responses were 56%. Median duration of response was 7 months. 6-month progression-free survival rate was 76.6, leading to a median progression-free survival 11.2 months. So the median time to response in both cohorts B and C was 2.1 months. Again, 6-month overall survival for the cohort C, for the C cohort was 93.9%. And the interesting thing is that the timing of brentuximab vedotin relative to the auto stem cell transplant did not affect efficacy. And that might have some meaning later on, because as of now, brentuximab As of now, nivolumab is approved for patients status post failure of auto stem cell transplant and brentuximab vedotin. So these results might help tweak the indication a little bit for the drug. In terms of select adverse events, this is separated into the safety population, which is all of the patients who receive nivolumab, too many drugs, nivolumab, and the efficacy population. So the efficacy population received more doses of nivolumab. So fatigue and pyrexia were seen in around 30 to 40% of patients, GI symptoms in around 20 to 30%, and upper respiratory tract infection, cough, pneumonia, and dyspnea were seen in around 15 to 50% of patients, which is a large range. And the grade 3 and 4 toxicities weren't bad, but if you look at pneumonia, 5.3% of the patients had grade 3 or 4 toxicity. So that's definitely something you want to look into. And again, the exclusion criteria were people with prior pulmonary disease. Other adverse events were rash and pruritus. Rash was seen in 31% of patients, with a 3.2% of those being grade 3 or 4. Musculoskeletal pain and arthralgia were seen in around 20 to 30% of patients. Peripheral neuropathy was seen in around 21% of the patients, with none of them being grades 3 and 4. And this is important because the major toxicity we see with brentuximab vedotin is peripheral sensory neuropathy. So we are happy that we have an agent that doesn't cause added peripheral neuropathy. Infusion-related reaction was seen in 18% of patients. There were no grade 3 or 4 events. Where we see grade 3 and 4 events particularly is with cytopenias, neutropenia, thrombocytopenia, lymphopenia, and anemia. So the incidence was around 27 to 37%, and 7% of patients had grade 3 or 4 lymphopenias. And again, these are heavily pretreated patients, status post-auto stem cell transplant. And as is the case with PD-1 inhibitors, we worry about immune-mediated adverse events. So we see that we had pneumonitis, colitis, hepatitis, endocrinopathies, nephritis and renal dysfunction, rash, and encephalitis. The incidences were low, and there seemed to be low grade 3 to 4 toxicities. If you look, hypothyroidism and thyroiditis was seen in 12% of patients, so we want to be sure to monitor the patients closely for that. So this led to nivolumab's FDA indication for Hodgkin lymphoma for adults with relapsed or progressed classical Hodgkin lymphoma after auto stem cell transplant and post-auto stem cell transplant brentuximab vedotin. The dose is 3 mg per kg IV over 60 minutes every 2 weeks until progressive disease or unacceptable toxicity. In terms of dose modifications, there are no recommended dose modifications for renal or hepatic dysfunction. However, adverse reactions do require dose modifications, and we'll be going over that a little later. Next, we'll be talking about pembrolizumab. The phase 1b trial, KEYNOTE-13, had many disease states in it, but we'll just be looking at the classical Hodgkin lymphoma cohort, which was 31 patients. These patients had brentuximab vedotin failure, auto stem cell transplant failure, or they were ineligible for transplant, good performance status, adequate organ function, and again, no autoimmune, interstitial lung disease, or CNS disease. Patients received pembrolizumab, 10 mg per kg IV every 2 weeks. And then depending on their response, they either were able to discontinue therapy after 24 or more weeks if they had a CR. If they had a PR or stable disease, they were treated for another 24 months or until PD or intolerable toxicity. And if they had progressive disease, obviously they were able to discontinue therapy, or they were able to continue therapy until it was radiologically confirmed. Patients received PET CT scans at 12 weeks and then every 8 weeks thereafter. Primary endpoint was complete response rate. Same thing, median age was young, 32% of patients. Previous systemic therapies were that over 30% of patients received 3 lines or more of therapy. 68% of these patients were refractory to the most recent therapy. All of them had prior brentuximab vedotin failure, and 29% were ineligible or refused a transplant. Actually, in the study, only 1 person of those 9 refused. The other 8 were ineligible due to refractory disease. So when we looked at the endpoints, they looked at transplant failure versus transplant ineligibility or refusal. And you can see that the total overall response rate was 65% in these patients. In transplant failure, it was a little higher at 73%, and in patients who were transplant ineligible or refused, it was 44%, which makes sense as these patients are basically chemotherapy resistant. CR was seen in 16% of patients overall, 14% of transplant failures, and 22% of the transplant ineligible group. And progressive disease was seen, and partial response was seen in 48, 59, and 22% of those patients, respectively. Stable disease was seen in 23% of patients overall, and 33% of patients in the transplant ineligible or refusal group. And progressive disease was seen in 13% of patients overall, 9% of patients in transplant failure group, and 22% in patients in the transplant ineligible or refusal group. The response seen within 12 weeks was seen in 80% of patients. Duration of response at 24 weeks was 71%. Progression-free survival at 24 weeks was almost 70%. At 52 weeks, it was 46%. And the median follow-up for surviving patients has been 17.6 months. What's important to note is 23 of the 31 patients discontinued treatment. 15 patients due to progressive disease. There were 2 stops due to adverse events. 3 patients went on to allogeneic stem cell transplant. 1 patient switched therapy. 1 patient had a CR, and 1 person withdrew consent. So when we look at adverse events in this study, you can see that hypothyroidism, diarrhea, nausea, and pneumonitis were seen in 10 to 16% of patients. And in terms of any grade 3 toxicity, we saw laboratory abnormalities such as increased AST, ALT in 1 patient, axillary pain in 1 patient. 1 patient had nephrotic syndrome and back pain. Colitis was seen in 1 patient, and joint swelling in 1 patient. There were no grade 4 adverse events. There were no treatment-related deaths. And again, there were 2 discontinuations due to adverse events, 1 for grade 2 pneumonitis and 1 for grade 3 nephrotic syndrome. So this led to Keynote 87, which was the phase 2 study. That had 3 cohorts. So cohort 1 had relapsed and refractory classical Hodgkin lymphoma after auto stem cell transplant and subsequent brentuximab vedotin therapy. Cohort 2 was ineligible for an auto stem cell transplant due to chemoresistance, and they also failed brentuximab vedotin. Cohort 3 had relapsed refractory classical Hodgkin's lymphoma after auto stem cell transplant, but they hadn't had any subsequent brentuximab vedotin therapy. Patients received pembrolizumab 200 milligrams IV every 3 weeks for up to 24 months. So in the phase 1 trial, they used 10 mg per kg. Here they found out that 200 mg IV every 3 weeks had similar pharmacokinetics and efficacy. PET scans were done every 12 weeks. Primary endpoint was overall response rate via blinded independent central review. Median age was pretty young. In cohort 2, the median age was 40, and age range went up to 76. Median lines of previous therapy, up to 2 to 12 previous lines of therapy, and up to 99% of these patients had 3 or more previous lines of therapy. All of them had relapsed and refractory disease after 3 or more lines of therapy. In cohorts 1 and 2, 100% had prior brentuximab vedotin use. In cohort 3, only 42%. And around 20 to 40% of patients had prior radiation therapy. So when we look at response rates, in all patients, the overall response rate was 69%. Again, that's pretty amazing in this patient population. But when we look at patients who had relapsed refractory classical Hodgkin's lymphoma after auto stem cell transplant and subsequent brentuximab vedotin, the overall response rate was still 74%, with 21% of those being complete responses and 52% being partial responses. In cohort 3, we also saw good response rates of 70% with good CRs and PRs. Now, in cohort 2, where they were ineligible for stem cell transplant due to chemoresistance and they failed brentuximab vedotin, they still had a good overall response rate at 64.2% with good CRs and PRs. It was a little lower, again, because these patients are chemo-refractory. Stable disease and progressive disease are shown below. and the duration of response was 75.6% in all patients, 82.2% in cohort 1, 70% in cohort 2, and 75.6% in cohort 3. The median number of cycles patients received was 13, and the median time to response was 2.8 months, with a range of 2.1 to 8.8 months. When they did a subgroup analysis, they looked at patients with primary refractory disease versus patients who relapsed after 3 or more prior lines of therapy. And you could say that, again, patients with primary refractory disease, they had a good overall response rate of 79.5%, with good CRs and PRs, and patients who relapsed after 3 or more lines of therapy, they still had a good overall response rate of almost 68%, with good CRs and PRs, but it was a little lower. Progressive disease in these patients, 11% in the primary refractory disease group versus 13.7% in the progressive disease group. So when we look at adverse events, you can see that patients had fatigue and pyrexia most commonly, with low grades of grade 3, cough and dyspnea, same types of adverse events that we saw with nivolumab, musculoskeletal pain and arthralgias, GI side effects, rash and pruritus. Hypothyroidism, again, seen in 14% of patients with 0.5 grade 3, upper respiratory tract infections, headaches, and peripheral neuropathy. Again, peripheral neuropathy was seen in around 10% of patients with no grade 3 or 4. In terms of laboratory abnormalities, we saw increased transaminases, increased alkaline phosphatase, and increased creatinine in patients. And again, where we saw the most grade 3 or 4 effects, adverse events, was with cytopenias, anemia, thrombocytopenia, and neutropenia. So pembrolizumab has the indication, and it was just approved, which was very exciting and led to a mad scramble for updating slides. But it has the FDA indication for Hodgkin lymphoma for adult and pediatric patients with refractory classical Hodgkin lymphoma or who have relapsed after 3 or more prior lines of therapy. It doesn't mention anything about having a previous auto stem cell transplant, so its indication is a little different from that of nivolumab. The dose for Hodgkin lymphoma is 200 mg IV over 30 minutes every 3 weeks until progressive disease or unacceptable toxicity, or up to 24 months in patients without progressive disease. The pediatric dose is 2 mg per kg, up to 200 mg IV over 30 minutes every 3 weeks. Dose modifications, again, renal dysfunction, no dose adjustments are required. Hepatic dysfunction, if they have mild hepatic dysfunction, no dose adjustments are required, and it hasn't been studied in patients with moderate to severe hepatic dysfunction. Again, adverse reactions require dose modifications. So how do we do that? So in terms of the general management for immune-mediated toxicities, we look at the grade, their management, and how to follow them up. So patients with grade 1, you can continue therapy or consider delaying therapy, treat the symptoms. Follow-up, you have frequent monitoring. If it worsens, you can treat them as a grade 2 or a grade 3 or 4. Patients with grade 2 toxicities, you delay treatment, you treat the symptoms, and you can resume therapy for the most part when symptoms are grade 1 or less. If the symptoms persist for 5 to 7 days or more, consider adding 0.5 to 1 mg per kg per day of methylprednisolone or equivalent, and then taper when the toxicity is grade 1 or less. If it's worsening with steroids, you can treat as a grade 3 or 4. If you have a grade 3 or 4 toxicity, discontinue therapy. Initiate a higher dose of methylprednisolone or equivalent at 1 to 2 mg per kg per day, and consider hospitalization. So with grades 3 or 4, you continue methylprednisolone or equivalent until the symptoms are grade 1 or less, and then taper steroids over 1 month or more. And with the caveat that if you're going to give steroids for that long of a time, prophylactic antibiotics, especially against pneumocystis, should be considered. And if patients have persistent or worsening toxicities, consider other immunosuppression. Other agents that have been tried have been infliximab and mycophenolate. Sorry about that. Now, again, these are just general managements. If you actually look at the package inserts for nivolumab and pembrolizumab, they have detailed information outlining how to manage these immune-mediated toxicities. So lately, there's been some news about PD-1 inhibitors and allogeneic stem cell transplant. There's been a new warning and precaution issued by the FDA for both nivolumab and pembrolizumab. In nivolumab patients, 6 out of 17 patients died due to complication from allo stem cell transplant. 5 patients had grade 3 or higher acute GVHD. 2 patients had hyperacute GVHD. 6 patients had a steroid requiring febrile syndrome. 2 patients had encephalitis, and 1 patient had VOD. With pembrolizumab, 2 out of the 23 patients who went on to allo transplant died due to complications. 6 patients had GVHD, 2 patients had VOD. So you have to monitor these patients really closely for the above and other immune-mediated reactions in general, and also especially if they're going for an allo stem cell transplant. So you have to really exercise caution when you're considering the next step for these patients. So there's still some questions and concerns about PD-1 inhibitors. Firstly, the duration of response. Longer follow-up is needed. It looks good and they seem to hold promise, but we do need longer follow-up. And the duration of treatment in responders. These are not cheap therapies. The cost is $12,000 to $14,000 a month. So we want to look at, can patients respond if we retreat them? If patients do respond, we might not have to continue with therapy. We might be able to just treat them intermittently or have less frequent dosing. And again, they seem to be relatively well tolerated, but we still need to monitor them closely for immune-mediated adverse reactions and intervene early. Again, those include pneumonitis, colitis, hepatitis, endocrinopathies, nephritis and renal dysfunction, rash, and encephalitis. So here's your next ARS case. GE is a 32-year-old male initially diagnosed in 2014 with stage 4 classical Hodgkin lymphoma, nodular sclerosis. He has received the following treatments: ABVD times 6 with a CR, DAP times 3 for relapse disease with a CR, auto stem cell transplant, involved field radiation therapy for localized axillary relapse with complete response, relapse disease in multiple nodal sites, brentuximab vedotin times 8 cycles with progressive disease after initial response, and vinblastine was then started for relapse disease or progressive disease. Unfortunately, GE's most recent scan shows progressive disease. What is the most appropriate therapy for GE at this time? A, second autologous stem cell transplant, B, everolimus, C, nivolumab, or D, pembrolizumab, followed by allo stem cell transplant. And go. Okay, it looks like everybody's in. And great, the answer is C, nivolumab. There's not that much information about a second autologous stem cell transplant. Everolimus is associated with a lower response. Nivolumab is the correct answer, and pembrolizumab would be an option except for the fact that we're really kind of trepidatious about following that with an allo stem cell transplant. So good job. So just kind of to put this all together, as a treatment algorithm for Hodgkin lymphoma after failure of autologous stem cell transplant, what do we do for these patients? First, we try brentuximab vedotin or a brentuximab vedotin-containing regimen. Then if they fail that, you can go on to a checkpoint inhibitor, such as nivolumab or pembrolizumab, or use a checkpoint inhibitor clinical trial. Now, where does allo transplant fit in? We're not really sure. Maybe after BV or brentuximab vedotin or a brentuximab vedotin-containing regimen. Now, after they fail that, if they've gotten a checkpoint inhibitor and they continue to have progressive disease, and they're symptomatic, and your ultimate goal is to get them to allo transplant, you might want to try a combination chemotherapy regimen. Again, these are associated with high response, but a lot of toxicities. Or you can give them a chemotherapy combination regimen clinical trial, and then go to allo transplant. In terms of going directly to allo transplant after a checkpoint inhibitor, we're just not sure. Now, if patients aren't going for an allo transplant, or they're not that symptomatic, what you can try is single agent traditional chemotherapy, everolimus or panobinostat or lenalidomide. Those are those novel agents that have been looked at. A clinical trial, as always, radiation therapy if they have disease that's localized, or if they're doing okay, you can even observe them for a while, and you can go back and forth between these options to best manage your patient. Now remember, decisions are guided by patient symptom, age, comorbidities, disease state, and goals of treatment. So where do we go from here? Future directions. We're looking at combining immunotherapy as they've done in other cancers, nivolumab plus brentuximab vedotin, nivolumab and ipilimumab, pembrolizumab and lenalidomide, to name a few. And we also want to incorporate brentuximab vedotin and or PD-1 inhibitors into earlier lines of therapy. First line for high-risk patients, nivolumab and AVD, brentuximab and AVD. And we're also trying to incorporate them into second-line regimens. There are studies looking at brentuximab vedotin in ESHAP, brentuximab vedotin in ICE, and even nivolumab in ICE. So as you can see, we've made a lot of strides in treating these patients who have relapsed after auto stem cell transplant. Again, we need these patients to do well. They're a young population of patients. So even though we've definitely made advances, there's still room for improvement. So thank you very much, and I'll be taking questions. Any questions? Thanks. It's hard. Yes, hi, thank you.
Hey, Donald Harvey, Emory.
Hi.
Nice presentation on everything that's come about in a relatively short period of time in Hodgkins, particularly the most refractory population. I was wondering if you could comment on the lack of flat dosing recommendations for nivolumab versus all the other indications that it has.
That's a great question. The question has to do with why in Hodgkin's lymphoma the nivolumab dose is still 3 mg per kg as opposed to flat dosing. And at our institution, we are going to go towards flat dosing, but just because the trials were done with the 3 mg per kg dose, I think that's what people feel more comfortable with. But I think that we will probably be going to a flat dose in our institution. And also in terms of cost and dose rounding, we think that that would make more sense. But right now, since we're relatively new in using these agents, we kind of want to go more by what the clinical trials used. Are there any other questions? That was a good question. No. And what do you use at your institution? I'm sorry, like? Okay. Right, and in terms of whether or not to use nivolumab versus pembrolizumab, most physicians feel that it has to do with convenience. So since pembrolizumab is given every 3 weeks versus every 2 weeks for nivolumab, some physicians might go with pembrolizumab, but right now it's around 50-50, especially now that pembrolizumab just got its FDA indication. Any other questions? No. Thank you all so much.